Hi, this is the first of 3 recordings on respiratory disorders. In this recording, we're going to talk about these conditions. In the second recording, we're going to talk about these. And then in the third, we're going to focus in on asthma and COPD. So let's start off by going through a few basic definitions. So the first basic definition is hypoxia. So hypoxia can be split up into two parts. Hypo meaning less than, ox refers to oxygen. So hypoxia is when the oxygen levels in tissues is lower than normal, and it's caused by a change in the affinity of hemoglobin to oxygen. So what happens is you've got this hemoglobin molecule over here, and each hemoglobin molecule can bind up to 4 oxygen molecules. Now, the bond between hemoglobin and oxygen isn't fixed. So sometimes they can be stronger and other times they can be weaker. So if we look at the oxyhemoglobin dissociation curve over here, you can see that this curve over here is the normal oxyhemoglobin dissociation curve, right? Where you have the partial pressure of oxygen and its relationship to the saturation of hemoglobin to oxygen. So hemoglobin saturation is talking about the percentage of hemoglobin molecules that are bound, that have oxygen bound to them. So 100% saturation means all the 4 possible spots on the hemoglobin molecule have got oxygen bound to them. If it's less, then you've got less than 4, less than the maximum number of oxygen molecules bound to hemoglobin. What you can see here is that there's certain conditions where the bond between oxygen and hemoglobin is weaker. So decreased affinity means that the bond between oxygen and hemoglobin is weaker. So that means that oxygen, it's easier for oxygen to leave the hemoglobin molecule and to enter into the tissues. So in conditions where the bond is weaker includes when there's a high level of carbon dioxide and when the pH drops. On the opposite side, you have certain conditions where the bond between oxygen and hemoglobin becomes stronger. And what happens in these conditions is that hemoglobin is less likely to let go of oxygen. So the hemoglobin molecules is the bond between hemoglobin and oxygen is stronger. Oxygen is less likely to leave the hemoglobin and therefore less likely to enter into the tissues. So some of the conditions that increase the bond between hemoglobin and oxygen are when there's an increase in pH, acute alkalosis, or when the carbon dioxide levels in the blood drops. All right, so back to the basic definition. So hypoxia is when you have a reduction in the oxygen levels in tissues. Hypoxemia is similar to hypoxia, but over here we've got the emia, and emia means in the blood. So you've got low levels of oxygen in the blood, right? And that's what hypoxemia is. Hypercapnia and hypocapnia are two opposite ends of the spectrum. So capnia refers to carbon dioxide levels. So hypercapnia is when you have an increase higher than normal carbon dioxide levels, and then hypocapnia is when you have lower than normal carbon dioxide levels. Now, carbon dioxide is a gas that's exhaled. So we get rid of carbon dioxide every time we breathe out. And so when breathing slows down, as in the case of hypoventilation, carbon dioxide cannot leave the blood, cannot leave the system, and so the carbon dioxide levels increase. Similarly, when we hyperventilate, when we breathe more rapidly than normal, then what happens is we exhale more carbon dioxide than normal. And so the amount of carbon dioxide, the levels of carbon dioxide in the system drops. So you end up with hypocapnia. Now, there is a relationship between carbon dioxide and pH, and the relationship is this. So if there's an increase in carbon dioxide levels, then it means that this equation is driven to the right, and that leads to an increase in hydrogen levels. And you know, when there's an increase in hydrogen levels, pH drop, right? Because there's an inverse relationship between the concentration of protons and pH. This diagram over here just shows that both carbon dioxide and CO2 diffuse across the capillary membrane in the alveoli in the pulmonary system. So it allows the air that we breathe in, allows oxygen to go from the alveolar air into the pulmonary capillaries. And again, it allows carbon dioxide to leave from blood into the alveolar air, and then the carbon dioxide is then exhaled out of our system. Some more definitions has to do with a variation in respiratory patterns. So the first two are linked together. So ventilation is the rate of breathing. So hyperventilation is when you have an increase in ventilation rate, an increase in respiration rate, and hypoventilation is the opposite. So hypo is less than. So hypoventilation is when ventilation rate or respiratory rate drops below normal. Kussmaul respiration is hyperpnea. And this is when you have an increase in ventilation rate, but it's very rapid tidal volume. So it's if you are breathing after you exercise strenuously. So not only is your breathing becoming more rapid, but you're actually gulping air in and out, right? The third respiration pattern is Cheyne-Stokes respiration. So in this, what happens is the brainstem, the one that controls your respiration rate, only responds to changes in the partial pressure of CO2. So basically, there's a alternating patterns of tachypnea, rapid breathing, and apnea, absence in breathing. So what happens is during the apneic stage, when there's no exchange of air in and out of the lungs, what happens is the CO2 levels increase. And then it reaches a state where it triggers breathing. And so there you have the tachypnea. And then with the tachypnea, what happens is CO2 is exhaled. And so CO2 levels then drop. And they drop to a level where breathing stops, right? And then when breathing stops, CO2 levels then continue to rise again until it reaches a level where it triggers the brainstem to actually start breathing rapidly. So you've got apnea here, followed by tachypnea, where CO2 is exhaled. And then when CO2 levels drop, it causes an absence of breathing, apnea again. And then CO2 levels increase to cause that rapid breathing. And then you've got the Cheyne-Stokes pattern of respiration. Some disorders of the airways and lungs that we're not going to cover in detail, but just as definitions here, because they will actually appear at some points throughout this these series of recordings. The first one is bronchiectasis. And bronchiectasis is when you have a persistent, so chronic abnormal dilation of pockets of the bronchi. So you've got the bronchiole here, and you've got the bronchial smooth muscle over here. And what happens over here is you have these pockets of abnormal dilation. So when the bronchiole become bigger than normal, so this is called bronchiectasis. The other term is bronchiolitis. And again, itis means inflammation. So bronchiolitis is when you have inflammation of the bronchioles, which then leads to bronchoconstriction. So instead of the bronchioles being this wide, bronchiolitis restricts the diameter of the bronchioles, and that means that there's less air going into the lungs, right? So that inhibits the amount of air that can actually go in. And you can see it over here. So these are the normal diameter bronchial tubes. And in bronchiolitis, what happens is the airway, the lumen of the bronchioles becomes smaller than normal. And so it's easy for air to actually get into the alveoli, but it's harder for air to leave the alveoli. And again, we're going to talk about this as we continue on in talking about asthma and COPD. Other concepts that we're going to cover: ventilation, diffusion, and perfusion. So when we talk about ventilation within the context of the respiratory system, we're talking about the movement of air into the lungs and out of the lungs. So you've got inspiration when air moves into the lungs, and air moves into the lungs when the pressure within the thoracic cavity becomes lower than atmospheric pressure. And the pressure in the thoracic cavity becomes lower than atmospheric pressure when the volume of the thoracic cavity increases. And the volume of the thoracic cavity increases when the diaphragm contracts, so it becomes lower than normal. So you have an increase in the volume. And when you have a contraction of the external intercostal muscles to actually then increase the size of the thoracic cavity. So pressure inside the thoracic cavity drops, air moves from an area of higher pressure in the atmosphere into the lungs. Expiration happens when the opposite occurs. So when the diaphragm relaxes, thoracic volume decreases. And again, with the relaxation of the external intercostals, it causes the lung to recoil. So again, making the thoracic cavity volume smaller. And so pressure inside the thoracic cavity increases such that it's higher than atmospheric air. So air goes out, right? So that's ventilation. Diffusion is the passive movement of gases from an area of high pressure for that gas to an area of low pressure for that gas. So when we look at the air that's moving into the lungs and into the alveoli, there's a higher pressure of oxygen in the alveolar air compared to blood, and so oxygen diffuses into blood. But there's a lower pressure of carbon dioxide in the alveolar air compared to blood, and so CO2, carbon dioxide, diffuses from blood into the alveolar air. So that's diffusion. And then perfusion is a third concept. So perfusion is the movement of blood through the pulmonary system, right? So you've got blood flow into the pulmonary system from the right side of the heart. So blood goes from the right ventricle in through the pulmonary trunk, the pulmonary arteries, and then into the lungs, where this is where the blood comes in. And so you've got this perfusion that's driven by the cardiovascular system through the heart acting as a pump and through the blood vessels in the pulmonary circulation. And then ventilation and diffusion is driven by the pulmonary system. So what we have here is we have a system of ventilation, air coming in and out of the lungs, and it needs to be matched by the amount of blood that goes into the pulmonary system. And so this matching is called the VQ ratio. So what we see over here is normally you've got normal amount of blood, normal amount of air going into the lungs, normal amount of blood going into the pulmonary circulation, and the ventilation perfusion ratio is normal, right? So you've got this situation over here where you've got deoxygenated blood going into the pulmonary capillaries from the right ventricle, and then you can see as it goes through into the capillary bed, what happens is oxygen enters into the blood, and then the blood becomes oxygenated, and then it gets oxygenated, and then it gets collected in through the pulmonary venules, the veins, and then into the left atrium. And so this is normal. When you've got the right amount of air going in, the right amount of blood going in, everything's hunky-dory. Now, in some situations, what you have is you have a low or very low VQ ratio. And this low or very low VQ ratio is depicted over here. And in these situations, what happens is that the amount of air going into the lungs and into the alveoli is lower than normal. So you've got over here, there's some sort of blockage in the alveolar duct, and so there's less air going into the alveoli, right? This is in comparison to the normal alveoli over here. And in a very low VQ ratio, where ventilation rates go down, what happens is you have a collapsed alveolus where it's almost little or no air going into the alveolus, right, through a blocked duct over here. And in both cases, you end up with hypoxemia, right? Low level of oxygen in the blood. Because there's less air going into the alveoli, then you don't have that oxygen diffusing into the blood, right? You have a reduction in the amount of oxygen that enters into the blood. When we have the opposite, when we have basically less blood going into it, so you see this high VQ ratio where you have the perfusion, the Q factor dropping below normal. What happens is this can happen in cases with a pulmonary embolism. What happens with this is the amount of blood that enters into the alveolar circulation in the pulmonary capillaries is lower than normal, right? So compared to, again, the normal alveolus over here, there's less blood going into this alveolus here. And when you have less blood going into it, you also end up with hypoxemia, right? Because there's not enough oxygen actually, and there's enough oxygen entering, but there's less blood for the oxygen to enter into, right? So we need the normal VQ ratio for things to actually function efficiently. Hypoxemia can be caused by either a low oxygen content of the air coming in, as is the case in high altitudes, or that the diffusion of oxygen across the alveolar capillary barrier over here is hindered, or you've got less air going in, or you have less blood going into the pulmonary capillaries. Some clinical manifestations of respiratory disorders are listed over here. So I've got 6 over here. The first one is dyspnea. So dyspnea is a feeling of breathlessness, shortness of breath, the feeling of not being able to get enough air. It's subjective and it's uncomfortable. Orthopnea is where you have a dyspnea depending on the body's position, right? So usually orthopnea kicks in when the individual is lying down. And what happens when the individual is lying down is this. When you've got a person standing up, what happens is the lungs, the fluid in the lungs can basically, because of gravity, can basically kind of be pulled towards the lower end of the lungs, and you've still got the ability for diffusion of oxygen and so forth to occur. But when the person is lying down, what happens is the lungs are sort of horizontally positioned, and so it's really hard for diffusion of air. And also, it says here, distribution of body's water. And when you're lying down, what happens is the abdominal cavity, abdominal contents puts pressure on the diaphragm, so the diaphragm can't work as efficiently. We've got cough. We all know what cough is when we're trying to expel secretions in the or excretions in the respiratory system. Can be either sputum or blood, hemoptysis. We've got pain caused by pulmonary disorders originating in the pleura. We'll talk about that, the airways or the chest wall. We've got cyanosis, where you've got this blue color, cyan, present in the lips or the digits due to an increase in CO2 content and a decrease in the amount of oxygen in the blood. We've also got clubbing. And clubbing is depicted over here, where you have these kind of enlargement of the distal digits. So they look like clubs, right? And this is due to chronic cyanosis, right? So cyanosis persists over a long period of time. You've got chronic cyanosis, as in the case of COPD, and clubbing can develop. On that note, we're going to start talking about specific respiratory disorders. So the first one is disorders of the chest wall. So I know you're familiar with that. Our thoracic cavity is protected by our ribs, right? And so what happens, as I said, is during inspiration, the diaphragm contracts, the external intercostal muscles contracts, and what happens is the thoracic cavity is enlarged so that the pressure inside the lungs is lower than the pressure outside the lungs, atmospheric pressure, and so air goes in. When we exhale, it's because the diaphragm is relaxed to decrease the thoracic cavity volume, as well as the lung recoils because of the relaxation of the external intercostal. So the thoracic cavity volume becomes smaller, pressure inside the lungs increase so that air goes out. Now, in a couple of chest wall disorders, first of all, we've got chest wall restrictions. And with chest wall restrictions, there's something in the chest wall that stops the ability of the thoracic cavity to freely expand and contract. And when the chest wall cavity cannot freely expand and contract, it inhibits breathing, right? So you can appreciate over here, when you've got these restrictions over here, either caused by either any of these, it inhibits the ability of this part, say, of the chest wall from being able to move freely, and so breathing in and out becomes inhibited. The second type of chest wall disorders is when you've got parts of the thoracic cage missing or weakened. So again, this is what happens normally. So you've got the thoracic cage here with the ribs being intact, and so when it expands, you've got air going in, right? Breathing in. When it contracts, you've got air leaving, right? And so the thoracic cage helps in increasing and decreasing the size of the thoracic cavity. In flail chests, what happens is part of that thoracic cage is missing, right? And so basically when you breathe in, it means that this part of the lungs that is missing with the missing thoracic cage gets sort of indented. But then when we breathe out, that bulges out, right? So flail chest can be either bilateral on both lungs or both sides, or unilateral, just on one side. and it can be caused by trauma, fracture of several consecutive ribs, or the sternum, the breastbone over here. And you can see this will actually hinder the ability of air to go in and out on an ongoing basis. We're going to go next on to pleural disorders. So just to remind you, we've got around the lungs, we've got what's called the pleura, right? So we've got the visceral pleura that's effectively stuck, a layer of connective tissue that's effectively stuck onto the outer surface of the lungs. And you've got the parietal pleura that's, again, effectively stuck onto the inner side of the thoracic cavity. In the middle, we've got the pleural space, and the pleural space usually has a little bit of fluid in it to help the lungs expand and contract as the thoracic wall expands and contracts. So that's normal. However, in two different pleural disorders, this efficiency is disrupted. So the first one is when you have pleural effusion, where you've got fluid, an increase in the fluid inside the pleural space. And so this fluid can be water, can be pus, or can be blood, right? In which case it's called hydrothorax, empyema, or hemothorax. And what happens is when you have fluid within an increase in the amount of fluid within the pleural space, it stops the lung from being able to fully expand during inspiration, right? So not as much air can actually enter in. And because you've got a reduction in the amount of air entering in, you've got a reduction in the amount of oxygen that can enter into the blood. And that can cause shortness of breath, coughing, or chest pain. The other kind of pleural disorder is called a pneumothorax. So a pneumothorax is when you have air entering into the pleural space. And the air can be outside air entering in from the atmosphere or due to a break in the chest wall and a break in the parietal pleura. And remember, the parietal pleura is the one that's stuck to the inside of the thoracic cavity. And so if there's trauma in there, then air can actually enter in and it can constrict the ability of the lung to expand. Or the other possibility is there's a disruption in the visceral pleura. And remember, the visceral pleura is the one that's stuck to the external surface of the lungs. And when there's a trauma or a break in there, then air can enter from the lung, from the alveoli, into the pleural cavity, in which case, in either way, what happens is you have an increase in air inside the pleural space. And again, you can see that the lung is collapsed, right? Atelectasis. And when the lung is collapsed, it cannot expand as efficiently. And so, again, you have a reduction in air going into the lungs. You end up with hypoxemia and hypoxia. So the treatment for that is to remove the air from the pleural space. And then once air is removed from the pleural space, the lung can inflate back up to its original size, and then respiration can occur as per normal. This condition, Croup, is also known as acute laryngotracheobronchitis. So again, itis means inflammation of the larynx, trachea, and the primary bronchus. And that's what it's defined as, right? Acute inflammation of the larynx, trachea, and the primary bronchus. So what happens when you have inflammation is that the lumen of the airway is decreased in size, right? And so what happens is there is an increased resistance to airflow, so air can't go in efficiently into the lungs. And then what it can do is can actually lead to, if it's not resolved quickly, collapse of the upper airway and respiratory failure. So croup is often seen in children under the age of 5, usually due to viral infection of the airways, RSV, and these are the manifestations. So runny nose, sore throat, low-grade fever, and a seal-like barking cough. The last condition is cystic fibrosis. So cystic fibrosis is an autosomal, so it can be inherited by either parent, recessive, so needs to be inherited by both parents, multi-system, so doesn't affect only the respiratory system, but affects other systems as well, that we'll see in the next slide. And it's caused by a defect in the gene, in a gene, and the gene that has a defect is the CFTR gene, and the CFTR stands for, CF stands for cystic fibrosis, the T stands for transmembrane and conductance, and the R stands for regulator. So what happens is that the CFTR gene is involved in production of chloride ion channels. So you've got here chloride ion channels that allows chloride ions to diffuse across the membrane. If that's defective, what happens is that the mucus that's produced becomes thicker than normal, right? So instead, this is in normal conditions, someone without cystic fibrosis. So you can see here the goblet cells produce mucus that's nice and thin and watery. And so the cilia, the hair-like structures that's associated with the epithelium of the respiratory tract, can help to move the mucus along so that we can cough it out or sneeze it out. If the mucus is thickened, right, if it's thicker than normal, it's heavier to move. So the cilia can't actually do this as efficiently. And what happens when the cilia can't do it, can't clear the mucus as efficiently, is that the bacteria basically stays within the respiratory system. So you end up with chronic bacterial infection, and then that causes chronic inflammation with the neutrophils, with the white blood cells, and then that causes pockets of this abnormal dilation of the bronchioles, right? When that happens as well, you have this bronchial ecstasies. You have an increase in the thickness of the mucus, and it can be impacted. It can basically just hang around there. You can end up with, again, an increase in a chronic bacterial infection, and you can also end up with cyst as well, right? So respiratory failure occurs because this mucus that's viscous, that's thick and dehydrated due to a reduction in the fluid content of the mucus is hard to clear. As I said, cystic fibrosis is a multi-system disease. So in this slide over here, you've got just the different systems that it can affect. So obviously it can affect the respiratory system, but it can also cause obstructive biliary tract disease. It can cause distal intestinal obstruction syndrome. It can cause infertility in males, again, because it blocks up the ductwork that the sperm has to travel in order to leave the male reproductive system. It can cause also a difference in the production of the sweat, right? So again, cystic fibrosis is a multi-system autosomal recessive disease because of the changes in the CFTR gene that leads to all these complications.